Okay. It is the voice of Indiana County, WCCS 101.1 FM, AM 1160, and WCCSradio.com. And Dr. Dan Clark joins us in the studio. Our visit presented by Marcus and Mack, voted best law firm and best personal injury lawyer 3 years in a row in the Best of Indiana County contest. Visit them online at marcusandmack.com. Good morning.
Good morning.
It's good to have you with us here today. We get to this time of the year every year, and we sort of pause in everything that we're doing because we want to focus in upon something that is an ongoing but yet hopeful topic for us, and that is colon cancer awareness. The statistics are still out there about colon cancer, its frequency, the dangers that it presents.
Right.
But the hopeful news is also a big part of this, and that is that IRMC and you and your team, they continue to meet it head on, and there are exciting advances in colon cancer treatment and screening too.
Right. There's been a lot of advances, just like in a lot of cancer areas, big focus on breast, but also colon cancer has had a lot of advancements in the recent years as well.
Well, let's talk a little bit about some of those advances, but let's start where we had Krista Pontani on with us last week talking about this. The need for screening, and it can't be overemphasized how important it really is.
Right. And, I listened to her interview. She did a great job. And, and the average risk patient should start screening now at age 45. Used to be 50. But we're seeing younger and younger patients with colon cancer nowadays, and whether it's environmental, which we think is a big factor in it, versus genetics. And, and I, of course, as you know, I do a lot of genetic counseling, and, genetics plays a significant role. We're understanding more and more about genetics with colon cancer as well, too.
If it's environmental, the environmental aspect of it, does that mean it's also regional, or is it more widespread?
It's widespread throughout the United States, and we have the highest rates of colon and breast cancer in the world. And, I always say undeveloped countries don't have a McDonald's or Burger King on every corner, not, pointing them out, but our diet has a lot to do with it. A lot of processed foods, you buy a fresh loaf of bread, you better eat in a couple of days or it's got mold on it. Buy some brand name breads and they can sit in your bread drawer for weeks. And that's not normal. And so what's in those breads, what's in everything that's out there, there's no one thing we can point to that causes this. It's multifactorial throughout the entire environment.
Yeah. And of course you say genetics, and you have been very much more than just a little bit interested in genetic research, in genetic markers that would peg somebody as being somebody who could be at potential risk.
Right. And as you know, I've been doing genetic counseling now. I keep saying 15 years. It's more like 17 years. It's been going on for a while. And I started with, back with colon and breast. And now, I always joke that when I first started, we were really just checking 3 main genes. And now we check over 48 genes routinely for cancer genes. And with colon genetics, it's really become apparent that that's a real significant portion of colon cancers now, especially if you have a family history. The average risk should get screened at 45, but if you have a family history of colon cancer, 1 or more first-degree family members with colon cancer, you should really start screening at age 40 with a colonoscopy, or 10 years younger than the youngest person. So if somebody had colon cancer at 45 in your family, you should start getting screening with colonoscopies at 35, not 45. So, that's what I really want to focus on is the high risk and the genetics, because I think everybody thinks, 45. And the newer screening methods out there, Cologuard, which is a great test. Cologuard has replaced the old, what we call finger wave, your doctor doing a digital rectal exam and wiping a little stool on a card and putting a little dye on it to see if there's blood in it. It's called the fecal occult blood test. Cologuard does immune assays for blood as well as genetic DNA for colon cancer. And it's good at picking up colon cancers. It'll pick up about 90% of colon cancers. It's not very good at picking up polyps. And what we really want to do is pick up polyps, not colon cancer. Because if we detect them at a polyp stage, you don't need me. You don't need a colon surgeon. You can get the polyp removed and prevent a cancer. So Cologuard drops down to less than 50% for large polyps and like less than 20% for small polyps. So it's good for detecting colon cancer, but it's not good for detecting polyps.
And what is good for detecting polyps is to actually have eyes on it, and that's the colonoscopy.
Right. The colonoscopy is 95% at detecting colon cancer and 95% detecting significant polyps. So it can prevent colon cancer. So if you just go by the Cologuard, you're just screening to see if you have cancer, not if you have polyps.
Yeah. All right. So let's talk about that screening. For many folks, it's something they don't want to get into, the colonoscopy, because everybody says, "Oh, that prep," and it's so tough. And it's not that it's tough. It might be a little bit for you daunting, but still, it's something that really is necessary and saves lives.
Right. Colonoscopy is still the number one test for screening. And, I've had mine, and, and after you reach 45, you should have it. The day before is the worst part of the test, doing the prep. Now the preps have gotten better. We don't have to drink this gallon jug of Go Lightly anymore. That was the really horrible stuff. We have different preps now that work better and are less volumes to take and everything. But, it gives you the runs. And the idea is that it's cleaning the colon out so you can see. If you do a colonoscopy and there's a bunch of stool in there, you can't see anything.
Sure.
And so that's the significance of the prep and the need for the prep. But, it's gotten better, but it's still, the day before you drink that, you get the runs, clean you out, and then, you're asleep for the colonoscopy, I think we've joked in the past, Michael Jackson loved that anesthetic, and he had, the anesthesia. When I had my colonoscopy, I woke up and I felt the most refreshed I have in a while, and I didn't even know anything had happened. So you go to sleep for, you're under what we call conscious sedation, and then you wake up and it's done.
When the surgeon detects that there is a polyp there, obviously polyps come in different sizes and different shapes, and they mean different things. Right. So interpreting what you find in there and then determining what is the way that I'm going to deal with that, that's a decision that's made on the spot. You don't have to reschedule to come back in and get that polyp taken care of. They'll do it right then.
Right. Surgeon or gastroenterologist, the gastroenterologists do the far more number of colonoscopies, and surgeons also do colonoscopies. But, you see the polyp, you take it out, and then it depends on what the pathologist says, but you actually take the polyp out at the time. And if there's not a cancer in the polyp, you're done. It's taken care of. There's no more intervention needed. The polyp's taken care of. If there's a cancer in the polyp, there's different stages, and it depends on the depth of the cancer in the polyp. If it's just in the tip of the polyp and a very early stage 1 cancer, the colonoscopy can take care of that as well. And so what they do is go back maybe 6 months later and do another surveillance to make sure it's gone. But you may not even need surgery if it's just a cancer in the tip of the polyp.
Dr. Dan Clark with us from IRMC, and of course we're talking about detecting colon cancer and the procedures that are best for addressing that, and certainly the removal of those polyps. They're not going to develop into a cancer if they're not in your body anymore.
Right.
And so that will be taken care of. For those who are diagnosed with colon cancer, obviously those progressions then take place, and IRMC is able to take you through that whole process too, working with the Hillman Cancer Center if necessary too.
Right. We have an excellent arrangement with the Hillman Cancer Center right on our campus. So every protocol that's available downtown at Hillman Cancer Center is available right here in Indiana. An excellent, medical and radiation oncologist. But the hope is if we catch it early enough, you won't even need them. But if you do, we have every protocol available here that's available through Hillman. And if somebody has a colon cancer, they come to me or to or Dr. Billen, who also does colorectal surgeon. And, we hired a new surgeon, Dr. Sam Cosciola, who's also trained in robotic colorectal surgery. He's currently at Armstrong Hospital and will eventually be joining us over here at Indiana as well. So we have the future lined up too. And he's a great surgeon and has great skills. But they come to us and we have to stage it. So the first step is to stage the cancer. if it's already out of the colon and spread, surgery's not going to cure that, and so I always say it's, closing the barn door after the horse is out, and so we first have to stage, and that usually involves a CT scan. All the venous drainage from the colon and rectum pretty much goes through the veins to the liver. That's why the liver is the number one spot for spread for colorectal cancer. So CAT scan will detect if there's spread to the liver. It also looks at lymph nodes, because that's the other way cancer spreads, is in the lymph nodes. So we get a CAT scan to look at the abdomen, look at the liver, look at the lymph nodes to make sure there's no obvious spread. That might need chemotherapy first. But if you get your colonoscopies early, you won't be faced with that.
Yeah.
So.
We're going to have you back in a couple of weeks, and we're going to talk more about colon cancer, the various treatment options, the hopes that there are for survival, and how that number keeps going up as well. But for today, again, we want to focus in upon that screening. What should people do? Is this go to your primary care physician and then get recommended, or do you go right to the person who's actually going to do the colonoscopy?
Most insurances now don't require a referral, but I always say check with your insurance policy first to see if you require a referral from your primary care doctor. So either go through them, or you can call the gastroenterologist up directly, that you're due for a screening colonoscopy. There's a big backlog, so, you have to get in now, if you're looking at it.
Yeah.
And then they can get you scheduled.
Yeah.
So.
You should go see that PCP anyway.
Right. That's right. The PCPs are very good at detecting, hey, you haven't had this done. You really probably should get it. Your PCP really should be talking to you about colorectal screening.
He's Dr. Dan Clark. Now, we're going to have Dr. Mukamala with us next week, but then you're back the week after, and we'll talk more about what is a problem that doesn't need to be the problem that it is.
Right.
Colon cancer. Thanks so much for the visit this morning.
Thanks.
He is Dr. Dan Clark. It is the voice of Indiana County, WCCS 101.1 FM, AM 1160, and WCCSradio.com.